Hello everyone, in this video we're going to be looking at the thoracic cavity and mediastinum section of the course pack. This resource is brought to you by the Scrubs team, which is the student collaborative resources for understanding and Brody success. My name is Bryce Pugh, I'm in the class of 2027, and we'll start with a look at the mission statement of Scrubs. So Scrubs is a student-driven initiative that aims to develop supplemental resources for current and future cohorts that will pass through Brody. Members of the Scrubs participate in a variety of subcommittees working to create resources for students by students. These resources aim to offer a unique perspective from students that have walked in the same shoes, developing resources that we wish we had been exposed to during our time in the course. The hope is this organization will become a staple of the Brody student body, exemplifying the unique collaborative community that Brody offers. If this is a mission that aligns with your goals and you have the desire to help those that will come behind you, as well as a goal to leave your mark on Brody as a whole, we invite you to join the team. Also, a quick disclaimer, the resources that are included in this document are made by the students, not by faculty. As such, there's a possibility of errors in the development, although this is mitigated via a team approach to development with multiple stages of vetting. If there's a contradiction with the coursework presented within your course, always go by the course documents. Additionally, Scrubs aims to develop supplemental resources. However, these are in no way replacements to the instruction of the Brody faculty. Use these resources as a supplement, but not as your primary source for course material. And so let's get started by looking at the bony thorax. And so this section that we're starting off now is the thorax and abdomen. And so our thorax is going to be this region that's kind of enclosed by our ribs, and it's going to go from our neck to our diaphragm, which will be a muscle here. And then below that, kind of at our stomach region, that's going to be our abdomen. And so a couple important things to know in the bony thorax. We have our thoracic cavity, which is the space between the ribs and the vertebrae and this group of bones here called the sternum. And so the sternum has a few pieces. We have our manubrium up here, our body, and the xiphoid process. One really important structure here is that the line that separates the manubrium and the body, this is known as the sternal angle, or the angle of Lewis. And this is really important clinically, which we'll look at later, because it's the location of the second rib. And so, looking at our ribs, we can further divide them based on how they attach. And so we have our true ribs, which are going to be ribs 1 through 7, and they're true ribs because the costal cartilage is going to connect directly from the rib to the sternum. We also have 3 false ribs, which are going to be 8 through 10, and they're named that because their costal cartilage connects to other costal cartilage, which will indirectly connect to the sternum. We also have 2 floating ribs, which are 11 and 12, and those are found most inferiorly. You can see them around here. They don't have any cartilage to connect to the sternum or anything. They're just going to end in abdominal musculature. Something else to look at here is going to be our thoracic vertebrae is in this region, and that's where they get the name that we've looked at. The vertebrae earlier, the thoracic, are going to be at the thorax. And the thoracic vertebrae are going to have these deep cup-shaped facets and transverse processes that will allow for rotation of the costal tubercles. The lower ones are going to have more flat facets, and that's going to allow for only a gliding movement of the tubercles instead of rotation. And we'll look at some of the movements later on. And then finally, we have our thoracic inlet, which is going to be up here, the entrance to the thorax, and our thoracic outlet down here, which is the exit. Our inlet is going to be bordered by just what you would imagine if you look at here. We have our manubrium anteriorly, the first pair of ribs laterally, and the first thoracic vertebrae posteriorly. Our thoracic outlet is going to be formed by our xiphoid process here, the costal arches from cartilages 7 through 10, the 11th and 12th rib down here. So it's going to kind of follow this shape, run around, and then it'll be the 12th thoracic vertebrae. And so looking at our thoracic wall, we're going to have a few different muscles. And so pretty much all of these are going to function for breathing in some way. And what they're going to do is extend from rib to rib. You can see all of the fibers here between the ribs. They're either going to go rib to rib, sternum to rib, or vertebrae to rib. And we're going to have 3 layers. We'll have a superficial layer, a middle layer, and a deep layer. And so before we look at all of the muscles, let's look at innervation, because most of them are going to be the same with an exception or two. And so nerves and vessels are going to run between the middle and deep layers of muscles along the costal grooves on the inferior border of the ribs. And so looking at all of our ribs, we have some muscles between the costals here. And so at the inferior border, there's going to be a groove. And we'll look at that more later. But in this region, we're going to have a bundle, which is going to be a vein, artery, and nerve that are going to run through here. And this is a really important relationship running from superior to inferior is van. So you can think of a van just driving down here, vein, artery, nerve. And right at the beginning, sometimes they'll be a little out of order, but they always sort themselves out to be vein, artery, nerve coming along here. And so innervation, skin and muscles are going to be innervated by the anterior rami of thoracic spinal nerves. And so the anterior rami coming off of T1 through T11 are going to be called the intercostal nerves. And so these are the nerves between our costals, intercostal nerves. These are going to innervate all of our thoracic muscles except the diaphragm, which is a little bit different. It's going to be innervated by the phrenic as well as the intercostals a little bit. And so they're also going to provide sensory innervation to the peripheral parts of the diaphragm and costal diaphragmatic parietal pleura. So pretty much all the muscles that we're going to be looking at are going to be intercostal nerves, or subcostal muscles will be innervated by T12. This is also a good point to think back to our dermatome map. So remember we had each of the rami are going to come off and give cutaneous innervation to this stripe-like pattern. And so we can see the thoracic vertebrae are going to give T2, 3, 4, 5, 6, like that. And so starting off with the muscles, we'll have one muscle in our superficial layer, one muscle in our middle layer, and then we'll look at the deep layer. So all of these muscles in the superficial and middle are going to be innervated by the intercostal nerves, the ones that are going to run between the costals, and function in mechanics of breathing. And so this is a really good diagram that I like. So we have our external layer, our external intercostal, which is going to be here. It's going to be originating from the rib tubercles to the costochondral junctions. And so our outermost layer is external intercostal. So superficial, external. Middle, we'll have our internal intercostal. And it's going to be really similar, but it's going to originate from the sternum and costal cartilages, and it's going to insert on the angle of the ribs. And so we have our external layer traveling this way, and our internal layer traveling this way. And a really important connection is that the internal intercostals run at a right angle to the external. So they're going to form this kind of like V shape in the fibers because one's going this way and one's going that way. Next, we'll look at our deep layer. And here we're going to have 3 muscles to look at. And so again, all of these are going to function in breathing in some way. And so first we have our transversus thoracis. And that's going to be these muscles here, or you can see here. And they're going to originate from the infero-posterior sternum, so the back lower sternum, and insert on superior costal cartilages. So you can see all of those here. Next, we also have our innermost intercostal muscles, which we can go back to a previous slide. That's going to be this one. So we have external, internal, innermost, and they're all intercostal because they just go between the costals. And so finally, we have our subcostal muscles, and they're going to originate from a rib, and they're going to insert at another rib. It's going to be either 2 up, or it can sometimes be a little bit more. And this is going to be our exception to the innervation. So here, we're innervated by the subcostal nerve. So subcostal muscle, subcostal nerve. All of the other muscles are going to be intercostal nerves. And so another really important muscle that we want to look at is the diaphragm. And the diaphragm is a really important muscle for breathing. It's going to be this weird shaped muscle that's kind of lining the inferior boundaries of the thorax. It's going to originate at the inner margins of the thoracic outlet and the superior lumbar vertebrae. It's going to insert on this central tendon that you can kind of see wrapped around here. And the muscle does continue around here and have this middle section, but it's blocked off in this picture. And so functionally, the diaphragm is going to be really important because it's going to play a major role in breathing. And so we've talked about all the other muscles play a role in breathing, although they're going to be a little more minor. The diaphragm is going to be a really, really key player here. And we'll look at exactly how breathing occurs and the mechanism, but essentially the diaphragm can contract, which will create a vacuum that's going to suck in air, and that's how you're going to inhale. And so innervation, this is going to be another one of the exceptions that you're going to have to remember. We have our phrenic nerve, which is going to come down from the neck, and it's going to give motor innervation to all of the diaphragm. Sensory innervation is going to be split. So our central region, which is hidden in this picture, the sensory of the central region is going to be phrenic. The peripheral regions, so out here, that's going to be innervated by the intercostal nerve. And so it's still just these two nerves that are kind of the key players here, but remember the difference between central is phrenic, peripheral is intercostal, all of the motor is phrenic. Now let's look at arteries of the thoracic wall. So this is a really good diagram that just shows all the different arteries we have. And we talked about how we're going to have the vein running between each of the costals. And so this is going to be the artery that we look at here. We also have some important ones like this. But the main things we want to look at is we're going to have two sets of intercostal arteries per space, and they're going to anastomose. So we're going to have a posterior intercostal and an anterior intercostal. The first posterior intercostal is going to arise from the costocervical trunk of the subclavian. The remaining branches are going to come directly off of the thoracic aorta. And so we can see that here with the fourth one and the third one, they'll just come directly off the aorta and they're going to wrap around. Our anterior intercostal arteries are going to arise from the internal thoracic artery or the musculophrenic artery. So thinking back to the previous unit, we had our internal thoracic or internal mammary artery, which is going to come down off the medial portion of the subclavian, and it's going to run all the way down here. It's going to give off a bunch of branches, which are going to be our anterior intercostal arteries. And so we can see that. The musculophrenic artery is another branch that's going to come off here, and it's going to give off more anterior intercostals. Next, we'll look at veins, and as you can imagine, those are going to be pretty similar to the arteries, and thankfully they're going to have pretty similar names too. So we're going to have posterior and anterior intercostal veins, and the posterior intercostal veins are going to drain into the azygos system, and this is going to be a really important system that we'll look more at in the mediastinum, but essentially it's going to be this vertical running vein that's going to receive a lot of blood. And so the posterior intercostals are going to drain into the azygos venous system. The anterior veins are going to empty into the internal thoracic veins. And so you can see those here. The posterior is going to be running around posteriorly. The anterior is going to be wrapped around anteriorly. And so now let's briefly look at respiration and the mechanism of it. And so what respiration is going to be our thoracic wall is going to move, and that's going to change the intrathoracic pressure. And so when we decrease pressure, for example, if we contract the diaphragm or release, kind of expand the bones, then that's going to be respiration. So decreasing pressure will give us respiration. If we increase pressure, which is going to be relaxing the diaphragm or kind of squeezing the bones, then we're going to get expiration. So increasing expiration. For looking further at respiration, we're going to have a few different movements that we can have. So our movements of the ribs supero-inferiorly, so it's going to be up and down. It's not this picture, but up and down. That's going to increase diameter via contraction and flattening of the diaphragm. So the diaphragm is a really, really important one. It's going to be the primary means of increasing thoracic capacity. And so contraction and release of our diaphragm is going to be the key component in breathing. And that's superior-inferior. Anterior-posterior, so that'll be this picture looking anteriorly at the sternum, posteriorly at the vertebrae. We're going to increase the diameter via the intercostal muscles elevating the upper six ribs. So you can see that would be here. The intercostal muscles are going to elevate it up, and that'll create this sort of pump handle movement, which is kind of depicted here. and that's gonna expand and have us breathe. We can also have lateral movement, which is described as this bucket handle movement. And what that's going to do is increase the diameter by lower rib elevation. So the lower ribs will get elevated like this. And finally, intercostal spacing is going to be maintained by our intercostal muscles. So the spacing between all of the costals is going to be maintained by these muscles. And that's really important to keep the ribs properly spaced as we're breathing. Okay, now let's look at the mediastinum. So this is going to be a really important area, and it's going to have a lot of really important structures that we need to look at and be able to group off. And so our mediastinum is going to be the central cavity in the thorax that's going to separate our pleural cavities. The pleural cavities are going to be lateral here, and that's the location of the lungs. And so between the lungs is our mediastinum, and that's outlined in green here. Our superior posterior bounds are going to be the superior thoracic aperture to the diaphragm. So it's going to be up here, up here. Our anterior posterior bounds, so front and back, that's going to be our sternum and costal cartilages at the front here. And then that's going to go back to the bodies of the thoracic vertebrae. And so, like I said, we're going to have a ton of different structures here. And so what we like to do, just like we saw with the neck, is divide it up into regions. And so the first division, we're going to take a really important landmark. We know our sternal angle is kind of right here or right here. And so let's get the sternal angle and let's just cut a straight transverse line right here across the thorax. And it's going to be horizontal. And so let's name that accordingly. Let's name it the horizontal transverse thoracic plane. And that's going to travel from the sternal angle to the intervertebral disc between T4 and T5. That's going to divide our superior mediastinum and our inferior mediastinum. Our inferior mediastinum still has a ton of different stuff. And so we're going to use some natural landmarks to further divide it into anterior, middle, and posterior. And so keep this picture in mind as we're going to go through and look at the contents of each of the different sections. So first, let's look at the superior mediastinum. So that's going to be in green up here. It's going to be continuous with the retropharyngeal space of the neck. And it's going to run from the superior thoracic aperture up here to the horizontal transverse thoracic plane. And so the contents of this is going to be, our mediastinum is like this big cave. And so up at the top, we're going to have some bats sleeping. So our bats are going to be sleeping at the top of the cave. And so we have our pet bats in the superior mediastinum, or petita bats. And so what this means, this is an acronym for all of our contents. And so first, the P, we have phrenic and vagus nerves. And so the vagus is going to come down. It's going to give off the recurrent laryngeal, which will go behind the subclavian on the right or the aorta on the left. And then it's going to pass posterior to the root of the lungs. So the vagus is going to pass posterior to the root of the lungs. The phrenic nerve is going to be passing anterior to the root of the lungs. And that's how you can distinguish the two. The esophagus is also going to run through the space. You can see that muscle here. And it's going to run in the midline and posterior to the trachea. In this region, we'll also have our thymus. And this is going to be located behind the manubrium of the sternum. And in adults, it's usually going to be replaced by fat. So when you're dissecting your cadaver, you're probably just going to see like a little lump of fat there that was previously the thymus. We also have the trachea in this region, which you can see here with the cartilage. It's going to come down and bifurcate into two primary bronchi at the inferior limit of the superior mediastinum. So trachea is going to come down and split and go to the two lungs. Bats, B, we have our brachiocephalic veins. So remember, looking at vasculature in the previous unit, we have a lot of blood from our head and neck is going to come down into the brachiocephalic veins, which are going to come together and form the superior vena cava. Our left brachiocephalic vein is going to be inferior and oblique to the right, and the left is also going to overlay the common carotid artery, the brachiocephalic trunk, and the left vagus nerve, and the left phrenic nerve. And so it's going to be, this is our superior vena cava, which is going to get fed into by our right brachiocephalic, left brachiocephalic. Here we're also going to have the arch of the aorta. And so that's not pictured super well in this picture, but we've seen our aorta. The arch is going to come up and go around. It's going to start off here and then run down. And so that's going to get crossed by the left vagus and the left phrenic nerve. We're also going to have the thoracic duct in this region, which we'll look at a little bit more later, but it's going to be this lymphatic duct that's really important. We looked at it briefly in the past unit, but it essentially gets lymph drainage from almost the whole body except for the right head and right kind of neck and shoulder. Finally, we have our superior vena cava that we looked at a little bit here. It's going to be on the right side, and it's going to get drained into by the azygous vein arch, which is going to go over the root of the right lung into the superior vena cava. And we'll look at the azygous vein later, but that's going to be all our main contents. So keep in mind, our pet bats are in the superior mediastinum. Next, let's look at the anterior and middle mediastinum. So anterior is going to be purple here. Middle is going to be the yellow. And so anteriorly, this is going to be in front of our pericardial cavity. So our middle is essentially going to be formed by the heart and some other stuff. And so anterior to that, we have our anterior mediastinum. This is going to be continuous with the superior mediastinum, and it's going to lay between the body of the sternum and the pericardium. And the pericardium is going to be this kind of sheath-like layer that wraps around the heart. And so in the anterior mediastinum, the contents are going to be the internal thoracic vessels. And so you can see that pretty well up here. Remember our internal thoracic artery and internal thoracic vein. They're going to come off and run down the anterior mediastinum. This is also the location of the thymus. Next, we have our middle mediastinum, and this is going to be occupied primarily by our heart. That's going to be wrapped around by the pericardium. And then we're also going to have the roots of our great vessels. That's going to be like part of our aorta, our pulmonary trunk, stuff like that. So that's going to be this region here. Also here, it's important to know the phrenic nerves and pericardiophrenac vessels are going to run between the pericardium and mediastinal pleura. Next, let's look at the posterior mediastinum, which, going back, that's going to be the blue region here. This is going to be another big one. This is going to be our dates and vagus. So in the posterior mediastinum, you're going on dates and vagus. This is going to be anterior to T5 through T12, which you can see here. And looking at the contents, D, we have our descending aorta. So we have the arch of the aorta that turns into the descending aorta and runs down the posterior mediastinum. We're also going to have our azygous venous system. And this is a really important and cool venous structure and system that's going to run up all along here. And it's going to drain the posterior thoracic and abdominal body walls. On the right, it's going to receive most of the intercostal veins, and it's going to arch over the root of the lung into the SVC. And we looked at that over here. So it's going to arch over the root of the lung into the superior vena cava. On the left, we're going to have, you can see over here, we're going to have our hemiazygos vein, and this is going to drain the inferior third of the thoracic wall and cross the midline into the azygous vein. So down here, hemiazygos will get the inferior third. We also have our accessory hemiazygous vein, which is going to drain the middle third of the thoracic wall into here. And then finally, we have our left superior intercostal vein, which is going to drain the superior third into the left brachiocephalic, which remember is going to feed into the superior vena cava. Also in this, in the posterior section, we have our thoracic duct, and we briefly mentioned that before, but that's going to be this green duct here. And this is going to be a really important lymphatic vessel because, like I said, it's going to receive lymphatic drainage from almost the whole body, except for this kind of top corner. It's going to ascend through the aortic hiatus, which we'll look at what that is in a second. And it's going to drain, or through the aortic hiatus, through the thoracic cavity between the azygous vein and the descending aorta. So this will be a good structure to identify in lab 2. You're going to have azygous vein, thoracic duct, descending aorta. In this section, we're also going to have our esophagus. And so you can see that here, it's been resected in this picture. But the esophagus is going to run down here. We're also going to have our splanchnic nerves, which are going to be preganglionic sympathetic fibers that are going to pass into the abdomen via crura off the diaphragm. And so think back to what the splanchnic nerves were in the first unit, but we're going to have those here coming down to go into the abdomen. And then finally, the dates in vagus, we're going to have our vagus nerves. And so the vagus nerves, we said, are going to run posterior to the root of the lungs, and they're going to become the esophageal plexus, which is going to recombine to form the anterior and posterior vagal trunks. So they're going to come down, and the vagus is going to become plexiform, and it's going to be on the esophagus as a plexus. At the bottom, more inferiorly, it's going to recombine to form the anterior and posterior vagal trunks, and that's going to keep running down with the esophagus. Okay, and now we'll look at, there are a few other contents that are not technically in the mediastinum, but that are going to be in this thoracic region. And so first is going to be the inferior vena cava, as well as the sympathetic trunks. And so these are not considered to be in any mediastinal compartment. So remember these two. This is a really important distinction, that neither of these are in any of the mediastinal compartments. And so the inferior vena cava is going to pass through the diaphragm and immediately enter into the right atrium of the heart. So we can see just right here, it's going to bust through the diaphragm and go straight into the heart. We also have our sympathetic trunks, which are going to run posterior to the lungs. So you can see those running all the way up here. We have our sympathetic trunk with all the ganglia, and that's not considered to be in any of the mediastinal compartments. Another really important correlation here is going to be what's traveling through the diaphragm. And so we're going to have 3 key structures that are going to pass through the diaphragm: a vein, an artery, and a muscle. And so most superiorly, we're going to have our inferior vena cava, and that's going to be the inferior vena cava hiatus, where it passes through, which is at T8. We're also going to have the esophageal hiatus, which is where the esophagus is going to run through. That's at T10. And we talked about how the vagus becomes plexiform and then gives off the vagal trunks along the esophagus. So it makes sense the vagal trunks are also going to run through here. Our aortic hiatus is next. That's going to be the descending aorta is going to pass through and become the abdominal aorta. And this is going to be at the region of T12. With this, we're going to have the azygous vein and thoracic duct. So we saw previously that these 3 are going to run together. And remember, it's from left to right, well, right to left. It's going to be vein, duct, aorta. And so those are all going to come down together. And a way to remember this is I eat apples at 8, 10, and 12. So I eat apples at 8, 10, and 12. And it's really important to remember these 3 structures, but I think it's equally as important to remember what is actually running with them, because that can commonly be missed, so make sure you know what's actually running with the important structures. And for the end of the video, let's look at a couple important clinical correlations. And so first we'll look at the sternal angle. So we looked at that. That's also known as the angle of Lewis. And this is going to be a really important reference point for identifying rib number and intercostal spaces, because if you can find the sternal angle between the manubrium and the body of the sternum, then you know that you're going to be at rib 2 if you go lateral. That can then be used to identify the intercostal spaces and ribs moving down. Also, to achieve thoracentesis, or local anesthesia of the intercostal spaces, you're going to want to place the needle just superior to the rib. because remember, we're going to have the van running at this costal groove. So we have our rib here that's going to form this costal groove, which is where our van is going to sit. And so if we stuck a needle just inferior, then we risk damaging the nerve or any structures here. So we're going to want to come up here and go superior to it. And this is a really important one to know. You want to go just superior to the rib because the van lies in the costal groove on the inferior border. Next, there's an anastomosis between the anterior and posterior intercostal arteries. We talked about that, but that's going to be really important clinically because your descending aorta is this huge vessel that's going to give blood to essentially your entire lower body. And if you have a coarctation that forms, which is just a narrowing of that vessel, then you're going to be severely limited in how much blood you can distribute throughout your body. And so this anastomosis between anterior and posterior intercostal arteries allows for collateral circulation so that we're not as dependent on our descending aorta. And then next, probably the most important group of clinical correlations is going to be rib fractures. And rib fractures are really common. There's going to be two kinds that we're going to consider here. You can have crushing fractures and direct injuries. And so crushing fractures, you can imagine if you're going to lay flat and you just had a hydraulic press coming down to squish you, it's just kind of compressing your whole thorax, then it's going to break your ribs at the weakest point. And this weakest point is going to be the sternal angle or the angle of Lewis. This is really, really common in car crashes or high-speed decelerating injuries. And they're really, really important because they can become lethal really quickly. And the major concern is because we look at the sternal angle here, that's the point that's going to break. If that breaks, then we're posing a risk to all these really important structures behind it right here. And the really important one that is really commonly ruptured and stuff like this is going to be the arch of our aorta. And so you can imagine if you rupture your aorta, that's not good. You're going to bleed out really, really quick. Another important structure here that we'll look at more when looking at the heart is going to be the ligamentum arteriosum. And that's going to be this little white structure here that's connecting the arch of the aorta to the pulmonary trunk. And that's another really susceptible area for injury here, because if that gets ruptured, again, it can become lethal really, really quick. With direct injuries, then the fracture can happen anywhere along the ribs. And this is commonly going to be at the middle ribs, just because of how exposed they are. And then you can imagine if breaking ribs in any way, this is going to be very, very painful because we're constantly using our ribs and rib muscles to move during breathing, as well as things like coughing and sneezing, but we're constantly breathing. And so if you have a fracture, it's going to be really, really painful.